Bottino, and for the next 15 minutes, I'm going to talk to you about the dreaded patellofemoral syndrome, or anterior knee pain. This is something that affects multiple specialties. It can be seen in pediatrics, primary care, family practice, and orthopedics. It's also something that occurs so frequently, you'll undoubtedly be asked about it by one of your relatives this coming holiday season. Speaking of, the holidays are right around the corner, and we all have that one family member that we dread seeing every year. Whether we like it or not, we know they're going to be there, and in orthopedics, patellofemoral syndrome is our version of that family member. So here's the breakdown for the next 15 minutes. We're going to discuss how to come to a proper diagnosis, and that means making sure we don't miss the bad stuff, identify the patient's risk factors for the condition, and see if they're modifiable or non-modifiable, and initiate treatment following a few pearls as to how to not make this worse. And at the end, know when enough is enough and it's time to refer. So what is patellofemoral syndrome? It's pretty simple. It's pain arising from the patellofemoral joint. You can see here that the patella sits in a groove on the femur called the trochlea. With overloading of that joint, pain can occur. This condition has many names, but no matter what you call it, it still causes the same type of pain. You may hear it referred to as patellofemoral syndrome, patellofemoral stress syndrome, patellofemoral pain syndrome, runner's knee, adolescent anterior knee pain, or if you want to get really fancy or bill a higher level visit, contralateral patella. While we know this can affect anyone, we see it more commonly in adolescent and young adult females who are active. You know that activity level can vary from something like competitive sports or the drama club or marching band. So how does this present? There will be diffuse, vague anterior knee pain. The pain is made worse by going up and down stairs or with squatting or kneeling. Pain going up and down stairs is pathognomonic for patellofemoral syndrome. Undoubtedly, if you ask the patient if they have pain going up and down stairs, their answer is going to be yes. Patients may also describe pain in the anterior aspect of the knee with prolonged sitting. This is something known as a positive theater sign. With COVID, we've actually seen an increase in this complaint due to prolonged sitting during virtual learning and lack of organized activity. Without fail, every time you ask the patient to localize the pain, they're going to wrap their hands around the anterior aspect of the knee. And if you ask them to point with one finger where the pain is, they're going to use that one finger to draw a circle directly around the front of the knee. There's no mistaking that this is patellofemoral knee pain. The physical examination is usually benign. There may be a lack of quadriceps definition, specifically involving the VMO, or vastus medialis obliquus. The quads may be tight. This can be measured by checking an Eli test. You have the patient lay prone, and you passively flex the knee. The heel should comfortably touch the buttock. If you can fit 1/5 distance between the buttock and the heel, or if as you're passively flexing the knee, the buttock rises, this is a positive test for quadriceps tightness. You can also check a Clark sign. This is performed by having the knee totally straight, and then you apply a downward pressure over the superior aspect of the knee, just superior to the patella. While you're doing this, you ask the patient to contract the quad, and this will create pain in the anterior aspect of the knee. This happens because during this, you're actually increasing force underneath the patella. Imaging is usually not necessary, but there is one exception to that, and that's unilateral pain. Patellofemoral syndrome most commonly occurs bilaterally, so if a patient comes in complaining of vague unilateral anterior knee pain, it's important that you get an x-ray. You don't want to miss something like an osteosarcoma or an osteochondritis dissecans of the knee. Both of these can cause diffuse vague anterior knee pain. So if you do get an x-ray, it's important to make sure that you get 4 views: the AP, lateral, the tunnel or notch view. This is the view where you'll most commonly see the osteochondritis dissecans that you saw in the prior slide. And lastly, the sunrise view. This shows how the patella sits in the groove on the femur or the trochlea. You can see here that it looks kind of like a train riding in tracks. The picture on the left shows a normal patellofemoral articulation. The picture on the right shows a lateral tilt of the patella, or the train is starting to ride off of the tracks. Both of these can be present in a patient with patellofemoral syndrome, but a lateral tilt may indicate an underlying alignment issue, predisposing the patient to anterior knee pain, and we'll dive into that a little bit deeper later on. So what causes patellofemoral syndrome? There's no clear answer to that, but we know that there are many factors involved that ultimately lead to overloading of the patellofemoral joint. Muscle weakness, patellar maltracting, and limb malalignment are a few common conditions that lead to patellofemoral joint overload. Now, these aren't mutually exclusive as they often occur together, and we'll break them down a little bit further in the next few slides. Muscular imbalance is the most common cause of anterior knee pain. This is something we see most commonly in adolescent-age females who are active, and it's easily addressed with physical therapy. You'll see a mismatch between the structures on the medial portion of the knee and the lateral side of the thigh. The VMO, or vastus medialis obliquus, and the vastus lateralis will have a mismatch where the VMO is actually weaker and the vastus lateralis is stronger, and this causes an uneven pull on the patella. The iliotibial band can also be involved if it's too tight, increasing the lateral pull. Miserable malalignment is something that Dr. Minkowitz spoke about earlier, and it's a term used to describe a combination of anatomic factors that result in uneven force across the patellofemoral joint. This is present when femoral anteversion, or internal rotation of the femur, and external tibial torsion, or external rotation of the tibia, occur together. The femoral anteversion combined with the external tibial torsion result in uneven forces across the patella, causing the patella to be pulled more laterally. Over time, as activity level increases and the knee repetitively flexes and extends, uneven force is placed over the patellofemoral joint, resulting in pain. Much like miserable malalignment, GENU VALGUM, or knock knees, seen here on the left, can result in abnormal forces across the patella, causing pain. In orthopedics, we love making things a little bit more complicated by measuring joint angles and using geometry to figure out how much force is being placed across the joint. But all of that complication is really unnecessary. A quick way that you can check for this in your office is to determine the intermalleolar distance. With the patient laying prone and the legs placed together, you then measure the distance between the two ankles. Physiologic GENU VALGUM is normal in little kids and resolves over time, but it becomes abnormal when it remains after 7 years of age. So therefore, if the patient is 8 years of age, the intermalleolar distance should be less than 8 centimeters. And if you don't have a tape measure in your office, you can just use 1/5, and it should be less than 1/5 distance apart. So I don't really know a lot about cars, but I recently learned the hard way that if your tires aren't properly aligned, it's going to result in abnormal wear of the tire in specific areas, seen here. This is my actual tire. So the result of this is pain. Why? Because it's really painful when you have to buy 4 new tires. And the patellofemoral joint is no different. So on the left, you can see a normal articulation of the patellofemoral joint, or like we talked about before, the train is riding nicely in the tracks. In the middle and on the right, you see more of a lateral pull of the patella, causing uneven wear and uneven force across the patellofemoral joint, and that results in pain. Okay, so we just talked about all of the reasons why this pain can occur. It's time to forget everything that I just said. I know your heads may be exploding right now, but here's why. No matter what the cause or what predisposing factors the patient may have, the initial treatment is always going to be the same. Physical therapy is the mainstay of treatment. NSAIDs and ice can be helpful for symptomatic relief, and activity modification can be useful to help remove stress from the knee. Bracing is optional. While it won't cure the problem, it can offer some symptomatic relief. Patients love to ask about what type of brace is the best for their knee pain. The truth is, most research shows that bracing is an effective way of treating patellofemoral syndrome, but even though that's the case, some patients still find relief when using a brace, whether it be psychological or just due to the stimulation of the sensory nerve. Therefore, if a patient states they'd like to try a brace, I usually recommend a simple over-the-counter slip-on knee sleeve like the ones you see here. So most patients respond well to physical therapy and no further intervention is needed, but setting realistic expectations is the most important thing that you can do for your patient. I always explain to patients that physical therapy will help them, but they have to be willing to work hard, supplement it with a home exercise program, and understand that this condition takes a long time to get better, so not to expect overnight results. The goal of physical therapy is to increase strength, increase flexibility, and decrease pain. This is achieved by following a specific strengthening and stretching program which targets the muscles that act directly on the patellofemoral joint. This specifically involves strengthening the VMO and hip abductors and stretching the lower extremity, including the quads, hamstrings, and iliotibial band. This is the rehab protocol that we provide to the physical therapists who work with our patients. I made it available to you as a handout. So if you want to initiate physical therapy out of your practice, all you have to do is write a prescription for physical therapy and attach this protocol to it. The protocol follows 3 phases. The goal of phase 1 is to decrease pain and initiate some gentle strengthening and stretching exercises. Phase 2 then progresses the strengthening and stretching exercises and adds in some light cardiovascular work. And then the goal of phase 3 is to get that patient ready to get back into their sport or whatever their activity is by mimicking that same type of movement and activity. Some exercises can make the pain worse when performed early on or with improper mechanics. Specifically, lunges, squats, the stair stepper, and leg extensions can overload the patellofemoral joint, increasing pain and making the problem worse. It's important that when these exercises are performed early, they're performed under the supervision of a physical therapist who can make sure that the mechanics are correct. The picture on the left shows the knee falling too far over the front of the toes, which increases stress on the patellofemoral joint. And the picture on the right shows that the knee is further back, therefore the forces across the joint have been decreased. And if you look at this picture, the knee falls too far ahead of the toes. And another thing that can overload the patellofemoral joint is deep knee flexion. So flexion beyond 90 degrees can create too much stress across the joint and cause pain. So when do we have to refer? If physical therapy isn't helping the patient, activity modification and NSAIDs don't help either, or if the story just doesn't make sense. We're able to evaluate for any underlying causes that might be driving the anterior knee pain or preventing it from responding to conservative treatment. It's rare, but sometimes the only option is to surgically correct whatever the underlying predisposing factor is. So to tie it all together, patellofemoral syndrome is a painful condition. If it doesn't sound like it fits the typical picture, make sure you dig deeper and that you're not missing anything. The good news is we know the majority of cases respond well to physical therapy, but if the patient isn't responding to initial conservative treatment, refer them to orthopedics to see if he or she is a good candidate for